Hello, welcome back. I hope you enjoyed your lunch and you're raring to go. As you know from our agenda, we were looking forward to having Frank Robin giving a keynote speech. He is a renowned expert in all matters related to e-health in Belgium. Unfortunately, we received the news that he has had a medical emergency. I believe he is okay, so he's okay, but he is in a hospital, so he cannot come. But he was so kind to suggest a replacement who we now have with us, and I will allow her to introduce herself more fully. The replacement is Hanne VUEGEN. I hope I pronounced your surname correctly, excuse me, who works for Departement Zorg, so the health department for the Flemish government. It's an interesting case study, just this, because we had a short conversation about it. Despite living in Belgium for many years now, I'm still not sure what the regional governments in Belgium do and do not do in terms of healthcare, etc. So I appreciate many of you are not Belgian and you don't live in Belgium. It's a world of immense complexity, as we might now just discover. So I welcome Hanne to the stage. Thank you very much.
Hello, everybody. I'm not going to explain to you about the Belgian politics and the regional and the federal situation. I will replace Frank, who cannot be here, unfortunately. Frank has been a key figure in the development of e-health and digital health infrastructure in Belgium, with a strong focus on trust, interoperability, and better use of health data for improved care. I will do my best to present his insights and share his perspective on the evolution of the Belgian health data ecosystem, Belgian integrated health records, and our roadmap towards EHDS. In Belgium, we have a federated e-health ecosystem where providers, hospitals, and regional hubs exchange data through shared platforms and services. I didn't know it was an animated presentation, so... The federated e-health ecosystem enables the exchange of key health information like the patient summary, what we in Belgium currently call the SUMER, electronic prescriptions, guidelines, advice, electronic referral letters, and so on. Resulting in clear benefits for patients and healthcare providers. And now we have the same problem, so I'm going to continue. Beyond the health benefits, the system aims to streamline and increasingly automate administrative processes. Overall, the objective is to reduce manual work, improve data quality, and make administrative processes more structured and easier to manage for healthcare professionals. In the next slides, you can see some usage figures of the Belgian e-health ecosystem. We have over 11 million registered consents for the exchange of health data, which is 97.3% of the Belgian population. We have over 19 billion transactions. In total, almost 115 million messages have been sent between healthcare actors through our targeted messaging system, and 12 million messages from healthcare actors to citizens' e-boxes, meeting 100% of the KPI targets. In order to connect the different data suppliers to the data users, the e-health platform provides a secure network and basic services. These basic services of the eHealth platform are a set of reusable technical services that support secure electronic data exchange in healthcare. And they include, for example, the eHealth box, consultation of the National Registry to access to verified patient identity data, secure authentication, timestamping, encryption, pseudonymization, and so on. These services are not applications themselves, but are maintained building blocks. For the Belgian integrated health record concept, what we call the BIR, we've been working on that since a couple of years. It's an environment where individuals have a clear, integrated view of their own health and welfare data, while all caregivers have access to the relevant information needed for high-quality continuous care. The aim is that all stakeholders can contribute to keeping data accurate, supported by services for managing, sharing, and decision-making, with the data also securely reused for research, innovation, policy, and population health. Some important key points of the BIR concept are seamless entry of high-quality structured data into the EHR systems supported by standardized terminology, for example, SNOMED-CT, and strict quality control. Enabling one-time data entry and reuse across care and registries, operationalization based on care episodes, optimizing one-time data storage, and coordinated health data platforms and tools are part of the BIR concept, enabling data use through dashboards for both primary and secondary use, and standardized care data sets aligned with European initiatives such as the European Health Data Space. This is an overview of the 15 data categories that are a part of the Belgian integrated health record. It's not completely the same as EHDS, but there is a very big overlap. And these are in accordance with the FHIR R4 standards, and including the different value sets where needed. The BIR concept is to be operationalized based on care episodes, and in the initial phase, co-creation will be done with focus on general practitioners, pharmacists, nurses, physiotherapists, and social workers. Apart from the Belgian Integrated Health Record and EHDS, where I'll come to in a moment, the eHealth Action Plan includes several other components like mobile health, literacy and inclusion, readjustments of incentives and financing. I guess this timeline is widely known, so you all know that we have until March 2029 to establish data exchange for the first group of priority categories, having an irrefutable impact on the supporting EHR systems. And for secondary use, data infrastructure and governments must be in use by 2029 as well. Some of the Frank's important provisions of EHDS. We know that EHR systems must meet European standards to be placed on the European market. The European Commission will develop a European digital testing environment and make this available as open source. And the Commission will provide the development, maintenance, hosting and operation of the infrastructures and central services required to support the functioning of the EHDS. The central services mentioned in primary use are interoperable cross-border identification and authentication mechanism for natural persons and health professionals, a central interoperability platform for digital health, which is My Health at EU, and some supplementary services. Belgium is holding on to a clear principle for our national implementation. We need timely adoption of unambiguous implementable European technical specifications in Fire Release 4. We need unambiguous and unique European structured semantic value sets for every relevant data element that are preferably SNOMED-CT, LOINC, DICOM. And software packages must meet European standards to be placed on the markets. In the Belgium, conversion to the European standards will be done as close as possible to the source of information when information is to be provided to health actors in another member state, and conversion to the Belgian national standards, if necessary, is to be done by the software packages of the user when information is retrieved from another member state. The patient has to be correctly identified, and the requesting party, which is the health professional, institution, or citizen, has to be strongly authenticated under EHDS, preferably high assurance, including the possibility of the European Digital Identity Wallet. The professional or institutional status must be validated by the competent member states, and the existence of a legitimate care relationship is confirmed across borders. Citizens must be confident that personal health data is only accessible to health professionals who have a healthcare relationship with them, and the data minimization principle established in the GDPR must be respected if we want EHDS to succeed. Regarding the electronic prescriptions, the creation is done in accordance with the law of the creating member states, and execution is done in accordance with the law of the member states where the prescription is executed. Then, in Belgium, we have an authentication app compliant to the EHDS regulation. It's called mygov.be. And in this Belgian wallet, digital identity authentication enables different features like access to the e-box and uploading digital documents like COVID certificates and driving licenses. The use of the Belgian digital wallet is also relevant in the context of the EHDS. Every Belgian citizen can upload, after authentication, the European insurance cards and the electronic prescription. Since both e-prescription and the authentication are EHDS compliant, the simple creation of a QR code will make it easily possible to retrieve medication in another European member state. There are still some concerns regarding the implementing acts. We should all ensure that the implementing acts remain feasible for industry, including small and middle-sized enterprises, do not increase costs for healthcare providers or member states, and do not introduce additional requirements beyond EHDS. They must rely on European Declaration of Conformity, use digital testing environments for the EHR systems, and avoid extra certification schemes. The digital testing environments must be available when implementing acts are published to support conformity testing and harmonized components, interoperability, minimum quality, identity, authentication, and proof of professional status and care relationship, including mutual recognition of test results across member states. And to close the presentation, via these to-dos, Belgium aims, together with other member states, to ensure that EHDS leads to a coherent and well-functioning European health data space through aligned architecture, coordinated implementation, and effective collaboration. Thank you.